So the diagnosis of non-epileptic attack disorder is made on the basis of video EEG. A patient is recorded or a patient is seen through a video during an attack of non-epileptic attack disorder, and it is clinically correlated with the findings of EEG during the attack. So if it's a non-epileptic attack disorder, the video EEG or the EEG of the patient during the attack will be normal. There will be no hyperactivity of the brain neuron during a non-epileptic attack disorder. One important point for the diagnosis of NEAD is that there will be a history of childhood abuse, either sexual or physical abuse. There will be history of either sexual or physical childhood abuse. So this was all about seizures and its types. Is it clear to everyone? Does anyone has any question?
Dr. Can you repeat the generalized seizures, like the tonic and then clonic? And
Generalized seizures are the seizures which involve the whole body. Generalized seizure can be tonic. Tonic means in which the body tone increases or the muscle tone increases. So tonic in which the body become rigid. Clonic means there will be jerky movements of the body. And tonic clonic movement means tonic clonic seizures mean rigidity followed by jerky movements of the body. And myoclonic means just jerky movements which are lasting less than 1 second.
so in myoclonic, there are jerky movements.
Yes, there are jerky movements without loss of consciousness.
Without loss of consciousness. Or
Yes,
with. Okay.
without loss of consciousness, and furthermore, they are of shorter duration because they are less than 1 second long.
Okay.
Basically, you cannot appreciate the myoclonic movements because they are short-lived.
Okay. That's fine. Thank you.
Any other question? So remember that we discussed it yesterday as well, that space occupying lesions such as abscess, tumor, and hematoma, all of them can cause seizure. So for the diagnosis of epilepsy, there need to be 2 unprovoked seizures 24 hours apart. A single episode of seizures cannot make a diagnosis of epilepsy. To make a diagnosis of epilepsy, there should be 2 unprovoked seizures. Unprovoked seizures mean the seizures which don't have any cause, like space occupying lesions such as abscess, tumor, or hematoma can cause seizures as well. Hypoglycemia can cause seizures as well. So to diagnose epilepsy, there should be 2 unprovoked seizures 24 hours apart. What are the anti-epileptic drugs that need to be given in pregnancy? Remember that sodium valproate, the most effective anti-epileptic drug is sodium valproate, but sodium valproate is very teratogenic. So it cannot be used in pregnancy. So if someone, an epileptic woman wants to get pregnant, then you need to stop sodium valproate before pregnancy and put her on carbamazepine or lamotrigine because they are less teratogenic. Plus, you need to add folic acid 5 mg until 12 weeks of pregnancy. Normally, the quantity of drug is 400 microgram. But if a patient is on anti-epileptic medication such as carbamazepine or lamotrigine, then the folic acid should be given. The dose of folic acid should be 5 milligram for 12 weeks of pregnancy. So if an epileptic woman wants to get pregnant, then you need to stop the child sodium valproate and put her on carbamazepine or lamotrigine. But if the patient that want to get pregnant and she is on sodium valproate, but there was no seizure in the last 2 years, then you can stop the anti-epileptic drugs. Then you can stop the anti-epileptic drugs, and you do not need to start carbamazepine or lamotrigine if the patient is seizure-free in the last 2 years. And if a patient on sodium valproate gets pregnant, then do not change the anti-epileptic drugs. You can only change the anti-epileptic drug before pregnancy. If someone on sodium valproate gets pregnant, then you cannot change the medication because she is already exposed to the sodium valproate. So adding a second drug or changing sodium valproate to carbamazepine and lamotrigine is not going to be beneficial but detrimental because carbamazepine and lamotrigine also have some risk of teratogenicity, very less than sodium valproate, but still there is a risk of teratogenicity with them. So if a woman on sodium valproate gets pregnant, you do not need to change the medication. You need to continue the sodium valproate because if you stop sodium valproate, she may get an epileptic attack which can be harmful for the mother and the baby as well. So the better strategy in this case will be that continue with the sodium valproate if a female gets pregnant while on sodium valproate. Remember that if a female is taking sodium valproate for her seizure and no alternate is available, according to recent NICE guidelines, uh, the drug of choice for treating epilepsy in women of childbearing age is lamotrigine or carbamazepine. Sodium valproate is not recommended at all in women of childbearing age because of its risk of teratogenicity. So that's why now the updated guidelines, NICE guidelines says that the drug of choice in women of childbearing age is either lamotrigine or carbamazepine. But if there is no control with lamotrigine and carbamazepine and the patient need to take sodium valproate for control of her seizures, then she should be advised to use effective contraception. In other words, she needs to avoid pregnancy while on this drug. So again, in established pregnancy, why changes to alternate epileptic drugs should not be undertaken? There are two reasons for this. In an established pregnancy, we should not change the medication or we should not switch to an alternate medication because changing the drug may precipitate the seizure and the child is already exposed to sodium valproate, so changing to another drug is gonna expose the child to one additional drug. So that's why in an established pregnancy, we should not change anti-epileptic medication. So this was all about the seizures and their management and the seizure management in pregnancy. Is it clear to everyone up to this point? If there is any question anyone want to ask, then he can unmute himself or herself and ask the question. Otherwise, we are going to start the next topic. You have 1 minute for any questions. Our next topic is dementia and its causes. What is dementia? Dementia is basically a chronic or persistent disorder which is caused by a brain disease or an injury to the brain and marked by the memory disorders plus personality changes. So a chronic disorder of brain which is manifested as memory disorders plus personality changes is known as dementia. So two things are important in dementia. There will be memory problems and there will be personality changes in dementia. And the third one is that it's a chronic disorder. Acute disorders of memory problems in older adults, they are called delirium. And chronic disorder in older adults that manifest as memory disorders and personality changes, they are known as dementia. So the first cause of dementia that we are going to discuss is normal pressure hydrocephalus. For the diagnosis of normal pressure hydrocephalus, remember this triad of gait abnormality, GDU triad, gait abnormality, D for dementia, and U for urinary urgency or incontinence. The triad of these three symptoms is known as Hakim's triad. Hakim's was the physician who described this triad for the first time. So that's why this triad is based on the name of that physician. Gait abnormality, dementia plus urinary urgency or incontinence in an elderly patients, the diagnosis will be normal pressure hydrocephalus. What are the investigation that you need to perform to confirm our diagnosis? A CT scan, of brain or MRI brain will confirm the diagnosis of Hakim normal pressure hydrocephalus. So if an old man present to you with triad of these symptoms, the initial investigation that you will order is CT or MRI of brain, which will show enlarged lateral and third ventricle. Now a latest test which is known as lumbar infusion test is also recommended by NICE guidelines. It is included in the NICE guidelines since 2019 or 20, I guess. So it's a more latest option. If diagnosis is unclear after a CT or MRI, then we can perform lumbar infusion test. Lumbar infusion test is that fluid is infused intrathecally and then CSF pressure is measured. The basic abnormality or a hypothesis which suggests that what is the basic abnormality in the normal pressure hydrocephalus. In normal pressure hydrocephalus, normally there is a decreased absorption of CSF. Due to decreased absorption of CSF, the pressure of CSF increases, which leads to the dilatation of the lateral and third ventricle. So lumbar infusion test is a good option to make a diagnosis of normal pressure hydrocephalus. During lumbar infusion test, fluid is infused intrathecally and the pressure of CSF is measured. As there is no absorption of CSF in normal pressure hydrocephalus. So after lumbar infusion test, if we measure the CSF pressure, it will be increased gradually as the fluid infusion is increased. It is also helpful in selecting the patient of normal pressure hydrocephalus who are going to need a ventriculoperitoneal shunt placement as a treatment option. So an older man or an older adult present to you with triads of gait abnormality, dementia, and urinary urgency or incontinence. The investigation that you will perform is CT or MRI of the brain, which will show lateral and third ventricle dilatation. Now you want to know that if the patient will be a candidate for ventriculoperitoneal shunt or not. You want to see if the cause is decreased absorption of CSF. Normal pressure hydrocephalus causes decreased absorption of CSF. You will perform lumbar infusion test, and if it's positive, then you can say that this patient is a candidate for ventriculoperitoneal shunt. Because there is a decreased absorption of CSF in the brain, so you will place a shunt between the peritoneal cavity and cranial cavity or ventricles, and the fluid or the CSF will be drained through peritoneal cavity. So it can lead to the resolving of the symptoms and the patient will get relief. So treatment is CSF shunt, which is also called ventriculopleural or ventriculoperitoneal shunt. So it can be placed between the ventricles and pleural cavity or ventricles and peritoneal cavity as well. Other treatment option includes acetazolamide. Acetazolamide is a diuretic which decreases CSF pressure. So it can also be used as a treatment option for normal pressure hydrocephalus. And if the patient is unfit for surgery for shunt placement, then serial lumbar puncture can also be done to relieve the extra pressure that is due to buildup of CSF in the ventricles. Now, the same patient with a triad of gait abnormality, dementia, and behavioral changes, urinary urgency or incontinence, but with a history of hypertension, smoking, or transient ischemic attack. So, an old man with Hakim's triad and with a history of hypertension, smoking, or transient ischemic attack. And MRI shows multiple lacunar old infarct. If any of these four is present or given in the question, then your answer will be vascular dementia. Then the cause of the dementia and these symptoms will be of vascular origin, of vascular disease or vascular problem. So that's why then we will call it as vascular dementia. If the patient has a history of hypertension or smoking or transient ischemic attack or MRI shows multiple old lacunar infarct, then it will be vascular dementia. So we have discussed two causes of dementia. One is normal pressure hydrocephalus, in which the basic abnormality is increased CSF pressure, due to which a dilatation of lateral and third ventricle occurs. And the second one is vascular dementia, in which due to vascular disease, the patient develops a triad of symptoms. Now, the third cause of dementia, is there any question up to this point?
I just wanted to ask, this dementia, this normal pressure hydrocephalus, can it happen with any elderly patient, or there should be some underlying cause for it?
It can happen in any older patient. Normal pressure hydrocephalus, if the old man has an abnormality with his CSF drainage system, then he can develop this triad.
And it is equal both in men and women.
Yes, it is equal both in men and women.
Okay, right. Thank you.
Any more questions? So the most common cause of dementia in older patient is Alzheimer disease. Alzheimer disease is the most common cause of dementia in the UK and in worldwide as well. Alzheimer disease is a genetic association as well, and the strongest genetic risk factor for Alzheimer disease is ApoE4 gene mutations. Alzheimer affects the patients or elderly who are above 65 years of age. Alzheimer consists of behavioral changes and memory problems both. The early manifestation of Alzheimer disease include that the patient has a short-term memory loss, but long-term or distant memory is intact, and immediate recall is intact also. So the early changes, so you can say that in Alzheimer disease, the memory problems start first and then personality changes or behavioral problems, while there's another disease which has similar signs and symptoms as Alzheimer disease, and that is frontotemporal dementia or Pick's disease. In frontotemporal dementia, behavioral problems start first and then memory problem starts. And also in frontotemporal dementia, the patients are the frontotemporal dementia usually affect the patient who are less than 65-year-old, and Alzheimer disease affects the patient who are mostly above 65 years old. And in Alzheimer disease, memory problems start first, such as short-term memory loss is the most initial symptoms in the patient who are affected by the Alzheimer disease. There is short-term memory loss, but distant and immediate recall is intact. Then after some time, along with memory problems, behavioral problems such as confusion or inability to do simple tasks, for example, cooking, inability to make decisions, and then progressive language deficits also occurs. And the most late manifestation of Alzheimer's disease is disorientation, easily getting lost. The diagnosis of Alzheimer's disease is based on MRI brain, and to differentiate it from frontotemporal dementia, the investigation that we need to perform is SPECT, single photon emission CT scan. On SPECT, in frontotemporal dementia, there will be involvement of two lobes, frontal lobe or temporal lobe. While in case of Alzheimer's disease, on SPECT, there will be global involvement of brain parenchyma. So if in the exam they ask you about the test which we can use to diagnose Alzheimer is MRI brain, and the test or the investigation which can differentiate Alzheimer from frontotemporal dementia, the investigation is SPECT or single photon emission CT scan. Now there is a short examination which is called mini mental state exam, which is used to assess the severity of cognitive impairment or severity of the Alzheimer disease. If MMSE score is between 25 to 30, then it is normal. And if it is between 21 to 24, then we can say that it's mild dementia. If the score is between 10 to 20, then it is moderate dementia. And if it's less than 10, then it is severe dementia. In the exam, usually MMSE score will be given and they will ask you about the management or the drug which can be used based on the score, based on the MMSE score. So pharmacological management, remember that these drugs, these are not cure for Alzheimer's disease. They will only improve the symptoms of the patient or improve the quality of life of the patient. Remember that in Alzheimer's disease, there is decreased activity of acetylcholine neurotransmitter, which leads to the development of these signs and symptoms. So acetylcholine esterase inhibitors such as rivastigmine, donepezil, and glentamine can be used in mild to moderate cases in patient whose MMSE score is between 10 to 24. The first line drug is rivastigmine, donepezil, or glentamine. Acetylcholinesterase inhibitors increase the activity of acetylcholine in the brain and increase acetylcholine. Acetylcholine is basically a parasympathetic neurotransmitter. So if a patient has a history of bradycardia, because acetylcholinesterase inhibitors can cause bradycardia or they can cause heart blocks. So someone with a history of bradycardia or heart block, you cannot use rivastigmine or acetylcholine esterase inhibitors. Then if the patient has a history of bradycardia or heart block, then you can use memantine, which is an NMDA receptor antagonist. So in patient with a history of bradycardia or heart block, Instead of first line drug, which is acetylcholinesterase inhibitor, we use memantine. And also the second indication for memantine is in the patient who has a severe dementia or whose MMSE score is less than 10. Classic scenario for Alzheimer disease for the Plab 1 exam is that if forgetful elderly, an elderly who forget things because the early changes in the Alzheimer disease is memory problems. So the classic scenario that is usually asked in the Plab 1 exam is that a forgetful elderly who forget to lock doors, forget birthdays, forget names of people and places, and easily getting lost and unable to do simple tasks such as cooking, then you will think of Alzheimer disease. Diagnosis is made on MRI brain, differentiated from frontotemporal dementia, SPECT is done, and management is based on the MMSE score. If it's mild to moderate, then rivastigmine, and if it's severe, then memantine. And also, if the patient has a history of bradycardia or heart block, then also memantine is used. Is it clear, everyone? The diagnosis, management of Alzheimer disease. Does anyone want to ask any question?
This acetylcholinesterase inhibitors are both rivastigmine and donepezil and galantamine. They all are
Yes,
acetylcholinesterase.
yes, they are all are acetylcholinesterase inhibitors.
Okay, so if the patient has this heart block or bradycardia, then on that basis we give uh, memantine.
Memantine.
Yeah.
Yes.
Okay, okay, that's fine.
Any more questions? Just for your knowledge, the questions that are usually asked in the mini mental state exam, these are some example of the questions. What is the approximate time? Questions are asked about the time and the spatial orientation, and then he is asked to draw some diagrams on the basis of which mini mental state exam or score is calculated. You don't need to memorize all this. You just need to memorize what MMSC signifies mild dementia, what signifies moderate dementia, and what signifies severe dementia. Now, an important table for you people to remember: cortical lobar function, function of different cerebral cortex lobe. There's frontal lobe, there's parietal lobe, there's temporal lobe, and one is occipital lobe. I hope you all know the function of occipital lobe. What is the function of occipital lobe? Can anyone tell me?
For vision,
Vision. That's right. What will happen if there is a lesion in the occipital lobe?
the patient might go blind.
The patient might go blind if both the occipital lobes are affected. What will happen if one of the occipital lobe is affected? Let's suppose right-sided occipital lobe is affected.
There'll be hemianopia with macular sparing.
Yes. If right occipital lobe is affected, then what kind of heminopia will it be?
Homogeneous, I mean,
then it will be left homonymous hemianopia with macular sparing.
Macular sparing.
Remember that the changes will be on contralateral side. If right occipital is affected, then left homonymous hemianopia, left side of the vision will be affected with macular sparing. And if there is lesion in the left occipital lobe, then will be right homonymous hemianopia with macular sparing. Macular sparing is important to remember because this is the only point on which you can differentiate it from other homonymous homeanopias, such as homonymous homeanopia that is caused by optic tract lesions, homonymous homeanopia that is caused by optic tract lesion. In those homeanopias, there is no macular sparing. Macular sparing is a feature only of occipital lobe lesion. So what are the important functions of frontal lobe? Frontal lobe is associated with personality, emotional control, social behavior, and contralateral motor control. So motor area, we discussed it yesterday as well. Primary motor area, secondary motor area, Broca's area, motor areas that control the muscles of the eye, they are all located in the frontal lobe. So along with personality, emotional control, and social behavioral control, frontal lobe also control the contralateral side of the body or the skeletal muscles of the contralateral side of the body. And language and micturition is also a function of frontal lobe. So if someone has a problem in the frontal lobe, then his personality will be affected, his emotional control will be lost, he will depict inappropriate social behavior, there will be language problems, and there will be micturition or urinary problems. So the physical signs that is associated with the frontal lobe lesion is contralateral hemiparesis,